Good morning. I'm Dr. Mulasheri Ajit Shankadas, and I'm the Director of STEMI India and the Chest Pain Clinics. It's with great pleasure we are making these slide presentations for you. So, the first presentation we have is of reperfusion, the modalities and results of reperfusion in patients. So, as you know, in India, there's a huge population and has a large share of STEMI. The younger population is about 20% of them who have early occurrence of disease and STEMI. And we saw in the Tamil Nadu STEMI project that about 20% of patients who are less than 45 had STEMI. Many of these patients are physical laborers, agricultural jobs and non-permanent jobs, and the stress is one of those issues which can create STEMI in many of these patients. Urbanization by itself is a problem. And the second most important thing is genetics and diabetes. Now, the lack of a universal insurance in India creates a large out-of-pocket cost, which then ultimately lands up with debts for patients. So, we need to have a system to create an insurance system for these patients. Now, what we need to do is also cross-subsidize these families across. So, a large patient base with small insurance would possibly cross-subsidize these patients and help them in their treatment. Now, in India, there is a preference for private care despite costs because of a possible distrust of government facilities, and it is important both to strengthen the public system and to make the private system collaborate with the public systems, and to push medical costs down so that patients don't avoid treatment and push them into poverty. The lack of awareness of health issues and the need for rapid access is one of the issues we have worked both in STEMI India and chest pain clinics. Now, we have to understand that we don't have optimal infrastructure in all hospitals and all centers, and transport logistics is a problem because of low traffic and dense urban population. There are few capable facilities in even urban structures, and the quality is a bit uncertain in these systems. Now, in the background, acute coronary syndromes, or what we call in common terms heart attacks, are caused by a sudden reduced blood flow to the heart muscle. And it is the most important cause of mortality and morbidity in the Asia-Pacific region. It accounts for half the global burden. That means almost 50% of the ACS patients are in the Asia-Pacific region, and there's annually around 7 million deaths and 129 million disability-adjusted life years due to acute coronary syndromes. Now, what is acute coronary syndrome? This is a typical cartoon of a coronary artery. Here is a plaque which ruptures partially, and the clot forms on top of this due to platelet aggregation. Usually, in the initial part, they do not cause permanent closure and damage to the heart. But when it causes a permanent closure in terms of a plaque plus a clot, it creates what is called as a classic heart attack, creating extensive heart damage. In non-STEMI, which is the other part of ACS, what happens is that the flows are still there, but there's an intermediate form where there's some trickle of blood flow, which causes less extensive damage to the heart, but it increases the troponin, which is a sign of heart damage. So, you run from unstable angina to the next step, possibly of non-STEMI, and sometimes STEMI. Sometimes it can move directly from unstable angina to STEMI, and sometimes it moves through the classic three ways. The ST segment elevation myocardial infarct, or STEMI, means on the ECG, there's an ST elevation in some of the leads, either the inferior or anterior. It's a presentation in almost 1/3 to half the patients of acute coronary syndrome. It is, as I told you, based on three typical issues: acute chest pain, a typical ST elevation based on ECG, and a troponin rise. We need 2 out of 3 to make a diagnosis of STEMI. It represents an acute thrombotic occlusion of an epicardial coronary artery. And what is important, it requires prompt recognition, triage, and reperfusion, because time is muscle. And if you waste your time in the diagnosis or in the treatment, you'll land up with myocardial damage. Now, if you look at myocardial infarction, you will know that if you treat it early, that's in the first golden hour, say, you may almost limit the myocardial damage to nothing. As the time progresses, and you can see that the myocardial damage is much more. For example, If there's a delay from D to C, which is a 60-minute delay, you will have a 30% more mortality. And there's very important that what we talk about the golden hour is early treatment of myocardial infarction due to mortality reduction. This was done by cardiologist Dr. Gersh, who published this in the JAMA, and it's the most relevant thing for reperfusion today. For example, if you do a time improvement from say A to B, which is 240 minutes late in the cycle, that is beyond the 6 hours, your mortality only reduces by 10%. So clearly what we try to say here is that mortality reduction is time dependent, and earlier you reperfuse, the better mortality reduction you get. So it's important that you have a critical time dependent period of a goal for myocardial salvage, and as you go later into the cycle, it is time independent. That means you do not get too much mortality reduction because of the muscle being less damaged, but it's open infarct related artery. That means that the artery is opened, so the remodeling of the heart is much better there.